Good morning. My name's David. I'm one of the community heart function nurses with West Berkshire, working with the Berkshire Healthcare Foundation Trust.
And I'm Lindsey Tilling. I'm a cardiology consultant with an interest in heart function, cardiomyopathy, cardiac rhythm management, and I work at the Royal Berkshire Hospital in Reading.
I will be giving you a very brief rundown of the signs and symptoms of deteriorating in late-stage heart failure, as well as investigations that you can do in primary care. So without further ado, first one is probably the most obvious when it comes to treating worsening heart failure, which is worsening breathlessness. This can happen at rest or on minimal exertion. It may present as orthopnea or paroxysmal nocturnal dyspnea. It can also be exacerbated by things like COPD, bronchiectasis, or other respiratory conditions. It is usually caused by an impaired gas exchange and impaired perfusion of the organs. All of these things with heart failure contribute to our symptoms. Our next one is increased fatigue, which is another core symptom of heart failure. It's one of the more difficult ones to treat. This can present as an overwhelming lack of energy, exhaustion after exertion. It's usually caused by things like chronic stress and strain on the heart, and again, lack of perfusion to the organs, just the ongoing stress that the body is under. We then have increased edema. This can present either slowly over a period of time, or it can be a sudden weight gain. Usually we say to our patients to look for roughly 1 kilo over 2 to 3 days, but obviously this will vary based upon the baseline size of the patient and the amount of water that they consume. And you've just got to use your judgment there. We've also got dizziness / hypertension, because they're related, but not always exactly the same thing. So most patients with heart failure will complain of dizziness, but that's typically with sort of certain activities like standing up quickly, bending down. This can be very brief bending down or after prolonged periods, and occasionally on reaching up. Not always associated with hypotension, but often there'll be a postural drop in the background. That's just something to take note of when you're assessing the patient, as this may affect their prognostic therapy. Another one of deteriorating heart failure is tachycardia. Now, this doesn't always present in the early stages. This is often just a sign that the heart is overcompensating for the lack of cardiac output and how this is affecting the body. We will still treat this as these compensatory mechanisms are often counterproductive over time. We've then got digestive issues. Now, this is often poor appetite, and this happens as a result of a lack of perfusion to the stomach and the bowel. We try to encourage our patients in these cases to eat a high-fat diet wherever they can tolerate food. We try to follow certain steps before considering things like a dietitian. And then the big one for deteriorating / exacerbated heart failure is hospital admissions. And really this underpins the entire approach to treating heart failure. It's one of the most common reasons for hospital admissions in the UK, the US, and Europe. And unfortunately, heart failure patients who are admitted to hospital have about a 20 to 30% mortality within about a year of admission. So it's really key that we do everything we can to keep them at home and maintain that quality of life. And this may mean that you require specialist input in these cases, either from us ourselves at the heart function team or specialists at the hospital. Moving on to late and end stage deterioration, many of these symptoms are quite similar to the deteriorated and exacerbated heart failure, but they may present in a more extreme level. And the big one is breathlessness again, as this is the one that has the greatest impact on quality of life for most of our patients at the end stage. This can be resistant to prognostic treatments. In some cases, it may benefit from sort of medications that help to relax the respiratory center, as this can give the patients a bit of respite from their often extreme anxiety associated with it. A lot of these patients sleep for long periods, and this will vary from one patient to the next at the end stage. There's no template for it. Some patients may require frequent naps during the day. Some patients may sleep for a whole day. And in really extreme cases, they may sleep for multiple days straight without waking to pass water, eat, drink. And often that is a really serious sign that we need to do something to keep them comfortable at home, because they're very near the end of their life. And we also see a great reduction in physical activity, and these all link together. Not every patient in this state will experience all of these, but they're often related. And it may be the breathlessness that keeps these patients from being active, or it may be fatigue. There may be other reasons. It's worth talking to the patient about it to try to identify if there's any way we can improve this. But many of these patients also struggle with cognitive decline, as you can see there. This can present as brain fog, confusion, poor memory. There's not a huge amount that you can do to treat this directly, and it's usually about optimizing their prognostic therapy if that's appropriate at this stage, but otherwise making sure that they've got appropriate care and that they're safe at home. Then again, we will sort of jump back there to hypertension. Obviously, the most obvious side effect will be dizziness. Many of these patients in the late stage, their blood pressure will naturally come down. We may need to reassess their prognostic therapy, particularly the antihypertensives. And sometimes it's a balancing act. We've got to maintain their symptoms, and often the treatment for that will make the hypotension worse, so you won't ever resolve both issues. Then something that really worsens this issue with hypertension in some cases is diuretic resistance. A lot of these patients at the end of their life are really resistant to loop diuretics. They have really stubborn edema, and unfortunately you end up in a bit of a spiral. In these cases, you may need to consider thiazide diuretics or thiazide-like diuretics like metolazone in order to manage this, and many of these cases end up on these diuretics for the remainder of their days to some extent with variable doses. The final one that I'll talk about is unintentional weight loss. This does tie back to our digestive issues and the lack of appetite, but unfortunately, in many of these cases, it's more cardiac cachexia, so we get a lot of muscle wastage, unintentional fat loss, etc. And this will often tie in with all these other symptoms where they're not moving much, they're breathless, they're confused. These all sort of, unfortunately, it's a bit of a spider web in terms of symptoms. But that's a basic rundown of the late and deteriorating stages of heart failure and how you might see these present. There are many more symptoms. Every patient is different. Some patients are very lucky and other patients experience all of these symptoms. Use your judgment, and if you need to discuss it with ourselves at the heart function team, please don't hesitate to make contact because we're very happy to help with these cases. The final thing that I'll talk to you about is investigations that you can do in primary care. Some of these may be really obvious to you, but bear with me. The first one is obviously a face-to-face physical assessment. These heart failure patients can be really difficult to assess remotely, and oftentimes they won't give you very clear answers about what's happening at home. We want to see, for example, how bad is the peripheral edema, if they have any at all. This may also present as upper body edema, particularly the abdomen. You may also get pulmonary edema without the peripheral edema. And that's what the benefit of auscultating is, but again, you don't need me to tell you that. We want to check their oxygen sats, blood pressure, and heart rate, because this is the sort of the foundation of implementing or escalating their prognostic treatment. And the final tip is be direct with your questions. I know I particularly find that patients can be very vague about how they're feeling and what's happening. An example would be if you ask a patient, are they breathless lying down, orthopnea? They'll say no, but what they won't tell you is that for the last 6 months they've been sitting upright with 5 pillows. So it's really important to sort of chase down the path of each question if you have the time, because that can really help you get things right for this patient. Blood tests, a lot of these are fairly self-explanatory. But just in case, we've got the NT-proBNP. This is an excellent diagnostic tool, but it's also one that we use progressively as the case goes on, because in some cases, if they've got a very high BNP level, this might help to guide you with whether or not these symptoms are related to the heart failure or whether you should consider alternative investigations. Usinase, again, obvious one, but helps us to sort of gauge what's safe in terms of prognostic therapy and how they've responded to it. And then CRP might identify an alternative reason for symptoms, for example, pneumonia for the breathlessness, cellulitis for the leg swelling, that sort of thing. And that will also obviously, as you know, be included in your physical assessment. Then we've got the full blood count and iron studies. Anemia and such are unfortunately a problem for a lot of our heart failure patients, and they may need or require iron supplements, be that tablet form or intravenous infusion at the Royal Berks or your other local health provider. And the final one there is thyroid. That can help us identify alternative causes for certain symptoms for these patients. And then I'll just very quickly run through these last few. We've got the ECG. This can help identify arrhythmias. We want to make sure these are well controlled, as this can affect the heart failure. For example, atrial fibrillation and atrial flutter have an ever so slight different target heart rate to general heart failure patients, but I'll let my colleague explain that to you shortly. And then bundle branch block morphology is really important for us to know, as a number of these patients will qualify for escalation of therapy later on down the line. We've got urinalysis. A lot of our patients are renal patients. They've got often advanced cases of chronic kidney disease. Albumin and protein creatinine ratio are really helpful to identify whether they'd benefit from input from the renal team. And then very quickly, again, we've got the chest X-ray that can help us identify causes of breathlessness. We've got spirometry and lung function tests, especially for patients who have a history of smoking, whether it's X or current, or working with chemicals, that sort of thing. Sleep studies is another one, just to help us identify sleep apnea, as this can really exacerbate the symptoms of heart failure. And then the final one, this may be with advice from specialists, is a repeat echocardiogram in certain cases, but that's a whole other talk for itself. If you want some advice about that, again, please contact the community heart function team. Thank you very much. I will pass you on to my colleague, Dr. Tilling.
Thank you. So I'm going to talk about the management of heart failure deterioration. If you've got a patient who you're fairly confident, based on your assessment and investigations, has had a decompensation of known heart failure, the first thing to do is to treat them with diuretics. That is the one thing that's going to make them feel better quickly. If they're not on a diuretic, then start them on something. And if they're on diuretics, don't be afraid to push it up. And I'd say particularly don't hold back in those with chronic kidney disease. There's a lot of people, understandably, in primary care and the community who don't have the reassurance of being able to do daily blood tests. But actually, the reality is if somebody has chronic kidney disease, they're going to need more diuretics. If they're already on diuretics, then they will have diuretic resistance and will require higher doses. So if the patient's already on a high dose, then I would consider adding in a different type of diuretic. Often patients are on a loop, typically furosemide, so I would then suggest adding in a thiazide, either bendrafluozide or metolazone. The next thing to add in would be an SGLT2 inhibitor, dapagliflozin or empagliflozin, if they're not on it already. This is licensed in both types of heart failure. So if the patient's not taking it already, it's worth getting it on board. It does have a bit of a diuretic effect as well. The only reason not to give an SGLT2 inhibitor would be if the patient is a type 1 diabetic, or if they have recurrent urinary tract infections, because SGLT2 inhibitors can sometimes promote recurrent infection. If you already know that your patient has got heart failure with reduced ejection fraction, the acronym being HFrEF, then the next thing to do is to look to optimize the 4 pillars of heart function management. If they're already on an ACE inhibitor or an angiotensin receptor blocker or an angiotensin receptor neprilysin inhibitor, then look to see if they can be increased. If they're not on one, then I would start with a small dose, perhaps something like ramipril to start off with. And if you're concerned about blood pressure, you can always give it in the evening, last thing at night. You also need to keep an eye on renal function after initiation of these drugs. A lot of people with HFrEF do have a low cardiac output, resulting in a low blood pressure to start with, but please don't hold back on trying the drugs. It's only if they have symptomatic postural low blood pressure that we should be cautious. The next drug to add in is the beta blocker. Again, there's really no reason why people with HFrEF shouldn't be on a beta blocker. Sometimes they run a fairly low resting heart rate. If the pulse is only around 60, you might want to hold back or only initiate a very small dose. The third class is a mineralocorticoid receptor agonist, MRA, spironolactone or eplerenone. These drugs have got really very strong evidence in HFrEF. The only sort of concern we have sometimes for primary care is around potassium, and you do need to check potassium a week after initiating these drugs. If the patient's not on one, absolutely, again, it will give them a bit of a diuretic effect as well as improving the pump function. Then the other thing to think about in primary care is comorbidities, which David's already alluded to. A lot of these people do have high blood pressure, which needs to be managed. diabetes, smoking, and obesity. For patients in atrial fibrillation, which is common in both forms of heart failure, it's important to try and manage the heart rate. Beta blockers can be useful for this, but also digoxin, which again has had some positive evidence very recently in some trials, can be useful both as a positive inotrope, but also for rate control. And of course, it's really important to ensure these people are anticoagulated. Most of them will score fairly high on the CHADS-VAR risk calculator. So finally, the red flags for urgent specialist review. So the people that we in secondary care want to know about. I think if you have a patient with heart failure and they're very significantly breathless, or it's really deteriorated quite significantly from where they were at baseline, particularly if you've already tried pushing the diuretics, then I'd want to know about that person. So if the patient is breathless whilst just sitting in a chair having a conversation with you, that would be labelled as NYHA class 4, or people with really very significant edema. So that's the people with the really very edematous legs swelling up to the groin and beyond. If they've got sacral edema, if they've got abdominal ascites, these are the people you're probably not going to win with when using oral diuretics. They may well need some intravenous diuretics, and it's something we can do on an ambulatory basis, or they might need admission, particularly if they're having skin breakdown. You get these fluid-filled blisters over the shins and start to break down the tissues, and again, that can really limit their ability. That will often need specialist help. Another issue is when people have a significant biochemical derangement. So I'd say if you notice that the renal function is really dramatically deteriorating, it's often a combination of the heart function deterioration, but also some of the drugs, as we've mentioned already, can exacerbate this. So if you're starting with an EGFR of 50 and it dropped to 30 and stayed there or dropped lower, then I would be concerned. If you're already at 30 and it drops to 20, again, you need to have an eye on that. But my rule of thumb is 20 points and beyond would be concerning. Similarly, with liver function tests, if you get a sudden increase from the baseline in bilirubin, ALT or ALP, that could be indicative of liver congestion as a result of the heart failure. So I'd want to know about this. These are the sort of people we'd like to see within our urgent 2-week wait clinic. And lastly, a real concern is if people have cardiogenic syncope. I'm not talking about a vagal episode, definitely not talking about postural hypotension, which can affect a lot of heart failure patients. As David mentioned, these are the people who are sitting, having a conversation, and then the next thing, they're on the floor. They have no warning. That's what cardiogenic syncope looks like, and it does speak to a serious rhythm problem. Often we know that people with severe systolic LV impairment are at risk of having dangerous rhythms, so those people absolutely should be flagged to a specialist centre urgently. Thank you.